Assalamualaikum. I am Dr. Nafia, lecturer, Department of Pathology. Today I am going to discuss about diagnosis of TB, which is tuberculosis. Introduction. Tuberculosis is the most prevalent communicable infectious disease in the earth. It is a chronic specific inflammatory infectious disease caused by Mycobacterium tuberculosis. Usually attacks the lungs, but it can also affect any parts of the body. According to the Global TB Report 2020, TB causes ill health among millions of people each year and is a leading cause of death from single infectious disease. In Bangladesh, the incidence rate for all forms of tuberculosis is 221 per 1 lakh population per year, and the mortality rate for tuberculosis is 24 per 1 lakh population per year. Characteristics of Mycobacterium tuberculosis. It is a rod-shaped aerobic non-motile acid-fast organism. It multiplies slowly and can remain dormant for decades. Diagnosis of TB. Proper history taking, physical examination and investigations. Routine blood test, radiological imaging and bacteriological tests can be done in case of investigations. History taking. We have to see some symptoms of active TB, which are cough, fever, fatigue, night sweats. We have to look for the symptoms of extrapulmonary TB, which are genitourinary symptoms, neurological symptoms, musculoskeletal symptoms, and some gastrointestinal symptoms. History of past treatment of tuberculosis. Past medical history like HIV or other immunosuppressive conditions such as diabetes mellitus. Drug history such as steroid. Social history, occupational homelessness, alcohol or drug abuse history. Physical examination. Cachectic patient, enlarged tender lymph node may be present in lymph node TB. In pulmonary TB, features of collapse, cavity or consolidation may be present. Crackles may be present, bronchial breath sound and percussion note will be dull. In extrapulmonary TB, may affect any organ and present with organ-specific feature. Investigations. Routine blood test, ESR may be high, lymphocytosis present. In radiological imaging, we can find apical lesions, collapse, cavity, consolidation may be present. Multiple miliary mottling present in miliary tuberculosis. Tuberculin test. Tuberculosis infection leads to the development of delayed type of hypersensitivity of tuberculosis antigen, which can be detected by Montauk's test. Procedure. 0.5 ml purified protein derivatives injected intradermally on flexor aspect of forearm. Interpretation. Diameter of the induration is measured within 48 to 72 hours. Interpretation. If the induration is more than 5 mm, then recent contact with an active TB patient, nodular or fibrotic changes on chest history may be found, and organ transplantation. If it is more than 10 mm, then recent arrivals less than 5 years from high prevalence countries, IV drug users, mycobacteriology for lab personnel, comorbid conditions, children less than 4 years old, infants, children and adolescents exposed to high risk categories. If it is more than or equal to 15 mm, then persons with no known risk factors for TB. The result sometimes can be false negative or false positive. False negative result comes in overwhelming TB, miliary TB, severe malnutrition, HIV, measles, immunosuppressive drugs. False positive result may become in patient with infection of atypical mycobacteria and BCG vaccination. Bacteriological test. Specimen collection from sputum. 2 samples are taken, one on spot and one on next morning. Gastric lavage in case of children. Extrapulmonary fluid examination such as CSF, ascitic fluid, pleural fluid, pericardial fluid. Tissue biopsy from affected site or enlarged lymph node. Direct microscopy. Gel Nielsen staining. Mycobacterium tuberculosis looks slender, straight or slightly curved rod with beaded appearance. Lead fluorescence microscopy is alternative to Gel Nielsen staining microscopy. Culture. It is not routinely used if direct microscopy is positive. When to do culture? Diagnosis of smear negative pulmonary TB where strong clinical and radiological suspicion. Media, solid media and liquid media. Solid media, Lowenstein-Jensen media after 6 to 8 weeks of incubation. Liquid media, Dept and MGIT. Faster detection of growth possible, higher sensitivity than solid media. Antibody detection by enzyme-linked immunosurveillance assay or ELISA, radioimmunoassay and latex agglutination assay. Newer test, rapid molecular diagnostic test which is GeneXpert, polymerase chain reaction, probe-based identification, ligase chain reaction, detection of adenosine deaminase level, serum ALS for TB, nucleic acid amplification test, interferon gamma release assay. Expert MTB or GeneXpert helps to detect DNA sequence specific for MTB. Rifampicin resistance can also be detected by it. Adenosine deaminase level. It is highly sensitive and specific for tuberculosis. Adenosine deaminase level usually detect in pleural and CNS TB. Interferon gamma release assay. It is helpful to detect latent TB. It is more specific than tuberculin skin test. Diagnosis of extrapulmonary TB. Smear or culture for AFB of body fluids like pleural fluid, pericardial fluid and CSF, ascitic fluid and urine. Histopathological examination or biopsy taken from lymph node, liver, spleen or spine. X-ray of involved structure like bone, spine, joint, adrenal gland, etc. Cytological examination of effusion, CT scan and molecular test which is GeneXpert. That's all for today. Thank you.